azoospermia would be elevated. And sometimes the testosterone, particularly in a patient of Klinefelter's syndrome, would be on the lower side. So now the current knowledge is that in a sizable proportion of patients of non-obstructive azoospermia, that is about 20 to 60% of patients, there are focal areas in which spermatogenesis is present. So the important thing to understand in these patients, that is of non-obstructive azoospermia, is that the pattern of spermatogenesis is pretty heterogeneous. And more the damage the testis, that is a patient of Klinefelter's or post-chemotherapy, mumps or chitis, or undescended testis, the more would be the heterogeneity which would be observed in the pattern of spermatogenesis. Now, when we discuss about non-obstructive azoospermia, there are a few pertinent questions that we plan to embark upon. Now, these are that which would be the best technique for sperm retrieval? What should be the timing of sperm retrieval vis-a-vis the ovum pickup? Now, is there any pre-treatment which may perhaps improve the sperm retrieval? Now, are there any prognostic factors? And what is the best clinical approach? Now, coming to one very commonly asked question, that is there any role for PISA or MISA, that is percutaneous epididymal sperm aspiration, in a patient of non-obstructive azoospermia? Now, going back, if you talk about a patient of obstructive azoospermia, then in such a patient, PISA is the most preferred option because the epididymis is pretty turgid and it is very easy, very cheap to insert a fine needle and aspirate, and many a time that aspirate would yield sizable number of sperms, which can facilitate assisted reproductive procedure. So does the same paradigm also hold true for non-obstructive azoospermia? So on the left of your slide is a pictorial depiction of obstructive azoospermia, and here we would aspirate from the top of the epididymis and not from the bottom, because at the top you would be having the most viable sperms. However, when you are doing a vasoepididymal anastomosis in a patient of obstructive azoospermia, then you would anastomose right at the bottom, because here you will have the most mature sperms. However, if you aspirate for a patient of obstructive azoospermia from the bottom, then these would be non-motile and perhaps dead sperms because of stasis. However, coming to the right of the picture where there is a non-obstructive azoospermia, you have to understand that since there is hardly any areas or very focal areas of spermatogenesis, therefore the epididymis is collapsed and usually it would not be having any kind of sperm. So PISA or MISA will not be working in a patient of non-obstructive azoospermia. Also, I would just like to touch upon the MISA thing. MISA is microscopic epididymal sperm aspiration, in which you dissect an epididymal tubule under a microscope and then you puncture it selectively, and many people also end up suturing it. Now, in a patient of obstructive azoospermia, MISA is something which is not to be encouraged, and the results that you get and the amount of sperms that you will get via a percutaneous epididymal sperm aspiration is as good as any other percutaneous procedure. So what are the sperm retrieval techniques in non-obstructive azoospermia? So you can have percutaneous and open techniques. In the percutaneous technique, you have the fine needle aspiration or the TESE, and you have the needle aspiration biopsy, which is also referred to as needle TESE, that is testicular sperm extraction. So coming to the FNAC part, now this is one paper that came from the UK, from Ironcroft, and he's a gynecologist, and initially the FNAC of the testis for sperm aspiration was propagated as a very promising technique, and in this the gynecologist would be making multiple punches in different directions through the testicular parenchyma. However, the subsequent studies have shown that the sperm yield in an FNAC is much lower as compared to the open techniques or a needle aspiration biopsy, and therefore FNAC has gradually gone into disrepute and is no longer practiced. Now coming to the second percutaneous technique, that is the needle aspiration biopsy. So the first question that is to be addressed is that, is it an innocuous technique? So first of all, we'll discuss the technique. This can be done under local anesthesia, or it can be done under a regional block. So most of us would do it under a local anesthesia with a cord block. Now talking about the anesthesia, is adrenaline to be used or not? Now logically, testis is an end organ, so the use of adrenaline is to be discouraged, but most of the practitioners do use adrenaline because the vas is a highly vascular structure. So whenever you infiltrate the vas, after that you must compress it for some time to avoid the formation of a hematoma. Now once the patient has been adequately anesthetized, a percutaneous puncture is made by an 18-gauge scalp vein, and it is made along the longest axis, which would be oblique and not in an anterior-posterior direction of the testis, which will be the shortest direction. So you have to understand that you have to pass the needle through the longest direction, and you have to rotate the needle. The needle, as you would understand, is beveled. So once you penetrate, then you have to rotate as you go inside the substance of the testis, and it has to be a single pass in one direction. And when you take out, then there is a suction with the help of a 10 ml syringe, and the feeding tube, the scalp vein tube has to be clamped so that the testicular parenchyma does not get sucked into the syringe. And once you are taking out the needle, then there is some amount of testicular tissue that comes out through the surface, which has to be held with the help of a microforceps, which is being held by the assistant. And gradually you can pull out as much testicular tissue as possible, and then you cut it. So one important point is that when you are inserting the needle, then the overlying skin of the scrotum has to be tightly pulled over the surface of the testis. Otherwise, when you withdraw the needle, then some amount of testicular tissue may be trapped between the testis and the scrotal skin. Now, this is a small video which would elaborate what I have just described. So this is the suction with the help of a 10 ml syringe, and this is the needle that has been inserted. The scrotal skin has been tightly stretched over it, and once you take out the needle, this is an 18-gauge needle, then the assistant is ready with the help of 2 forceps, and he would be grasping whatever tissue has been unraveled, and he will pull as much of testicular tissue as is possible. And once the tissue snaps, then after that you have to apply a firm pressure on the puncture site for a period of at least 5 to 10 minutes. So the second question that was on this slide is that the first question, in fact, was that, is a needle aspiration biopsy innocuous technique? Now, needle aspiration biopsy, like if you proceed on to do some open procedure to extract the sperms immediately after a needle aspiration biopsy, then many a times you will see that there is a hematoma under the tunica. So this has a potential of causing intraparenchymal hemorrhage, and it has a potential of causing significant disruption to the testicular parenchyma. And as you would understand, in a patient of non-obstructive azoospermia, already these testes are very much compromised. So maybe 2 to 3 needle aspiration biopsies are fine, but if you end up like making too many punctures within the testicular parenchyma, then there can be a significant damage, which may lead to further hypospermatogenesis and even decrease in the testosterone production. So now talking about the open techniques for the sperm retrieval and non-obstructive azoospermia. One is the conventional technique. Now, the conventional technique is as you have already seen, the amount of tissue that can be extracted with the help of a needle aspiration biopsy is perhaps as much as you get through a conventional testicular sperm extraction. So once you start doing a needle aspiration biopsy, then there is no place for a conventional open testicular biopsy. Now, there are 2 more techniques for sperm retrieval, which are microscopic technique. The first is the SST mapping, or the single seminiferous tubule technique. Now, this is a wonderful technique that has been propagated and that has been invented actually by Dr. Rupin Shah sir. And the second is the Microdissection TESE, which is very commonly practiced and is advocated perhaps as the only technique of microscopic sperm extraction in the West, particularly in the United States. So let us briefly understand both the SST mapping and the microdissection, and what are the differences between this technique. Let us try to understand that. Firstly, this is a diagram of the single seminiferous tubule technique, the SST mapping. In this, it is possible to take about 25 to 30 samples depending upon the size of the testis. So I would briefly describe the technique. In this, you expose the testis, then the microscope comes into the picture. If you don't have a microscope, then you can use a magnifying loupe also. So this is one leeway which this technique has, that even if you don't have a microscope, and you can perhaps still do an SST by using an operative loupe, which is not the case with a microdissection. So under magnification, you look for the avascular areas, and then a superficial puncture is made with the help of a 22 gauge needle. Now here, the tunica is not incised, and since there is no incision, so you don't require to suture anything over here. The puncture is then gradually widened by the single prong of a microforceps, and then by gentle pressure, the tissue is unraveled. And when you're doing this, then magnification is being used. So initially, you may end up extracting a seminiferous tubule, which is very atrectic, or it can be only gelatinous substance that is coming out. So you skip that particular site, and then you go to the next site, then the next, and then the next. At one point, you will have a good fat seminiferous tubule that is popping out, and then you can extract as much as possible. Now, this is a video of the SST technique. So here you can see that there is a 22 gauge needle. You pick up an avascular area. You puncture the tunica with the help of a 22 gauge needle, and then you insert the prong of a microforceps, and then you can see that a fat seminiferous tubule is popping out, and it is being extracted with the help of a microforceps. And if you observe carefully, then the amount of substance that you can take out through a SST technique is sometimes as much as a needle aspiration biopsy. The most important point about this technique is that there is no cut on the tunica. Since there is no cut, so there is no suturing. And depending upon the size of testis, you can sample up to 30 areas on one testis, and so it would be about 60 areas that are sampled in both the testes. So coming to the microdissection, one important point about the single seminiferous tubule technique was that it is sampling the surface. And when you're talking about the microdissection, then this is sampling the depth. So these two techniques may not exactly be in opposition of each other. They may actually be complementary because one of them is sampling the surface and the other is sampling the seminiferous tubules in the depth. Now, since this is a more commonly studied and reference technique, so I'm sure that everybody is like familiar with the technical points of the microdissection. So basically the testis is bivalve. So talking about the incision, it can either be longitudinal or it can be transverse. It basically depends upon the vascular pattern. So if you have a vessel running longitudinally, then you would plan your incision parallel to it so that there is a minimal amount of vascular damage. So it depends upon the vascular pattern, how you are planning your incision. Now, once you have bivalved the testis, then the irrigant that is used is ringyl lactate with heparin. And this is done, as I mentioned earlier, under magnification. So if you have an area which has like a fat seminiferous tubule, then that area would on magnification appear to be more yellowish than the surrounding areas. Sometimes you can have a scale in the eyepiece, so you can see the diameter of the seminiferous tubules. So theoretically, you know, this is purely theoretically, the seminiferous tubules whose diameter is less than 110 microns, usually the chances of retrieving sperms through them is pretty low. However, if the diameter is more than 270 microns, then there is about an 80 to 90% chance of extracting sperms from that particular seminiferous tubules. The practical experience is that the diameter would somewhere be in between these two figures, and the chances would be about 30 to 40%. So the seminiferous tubules which are nearer to a blood vessel on microdissection would harbor higher chances of having a sperm. So these are the tubules that need to be sampled. One very important point is that during a microdissection, the amount of tissue that you should be sampling should be as less as possible, so that you don't end up with severe hypospermatogenesis and you don't end up with a testis in which even the testosterone production has been compromised upon. Now, suture for closure is like you will take a non-absorbable suture. Now, ideal is a 6-0, but like a 6-0 needle would be more difficult to handle. So practically a Prolene 5-0 is used by most of the surgeons. Now, this is like more for general surgeons. I'm sure that all the urologists know that be it a microdissection or be it an open testicular biopsy, which hardly nobody does now, the suture always has to be non-absorbable. However, a lot of general surgeons, they believe that they should be using a suture which gets absorbed in the shortest possible time. So they sometimes use a plain catgut, and that elicits a severe inflammatory response, and you will end up having a granuloma at the site of your suturing several months after the surgery has been performed. So where microdissection is more helpful as compared to a single seminiferous tubule technique. So you have to understand that the smaller the testis, the easier it is to do a microdissection, because if you are dealing with a very large testis, then the amount of tubules that you have to sample would be very large. So microdissection is usually done for very small testis. It is done for testis which are fibrotic. So if you are trying to do a SST technique in a fibrotic testis, then on a puncture, the seminiferous tubule would not be popping out, and all you would be getting is some hard fibrous material. So these are the cases, small testes which are fibrotic are more to be subjected to a microdissection. Also, if there are very, very focal areas of spermatogenesis, maybe like a case of Sertoli cell only, then in this microdissection would perhaps score over the SST technique. And we shall be discussing about this point later on also. Now, one question that is asked is, what is the optimal number of biopsies that have to be done in order to sample a testis? So this is one slide by Turek. In this, basically, biopsy has not been done. They have done an FNAC. But you would see that in 3 FNACs, about 30% has been sampled. And then there is a plateau, and in about 8 biopsies, you have reached almost up to the top of the plateau. So you can keep on going for more number of biopsies, but the chances of finding a sperm will not significantly increase. So about 7 to 8 testicular biopsies is an optimal number in which you have an optimal chance of like picking up the maximum number of sperms. So now the question arises that should microdissection be offered in all cases of non-obstructive azoospermia, which actually is the practice in United States of America. Like when they chance upon a patient of non-obstructive azoospermia, then this is the recommended technique. This is the first line of surgical treatment as far as like the sperm extraction is concerned, which is advocated by them. So let us briefly discuss this question that should microdissection be offered to all the patients, and should it be the first modality of sperm extraction? Now, the advantage is that this has the best chance of sperm retrieval. This is something which is a fairly established fact, but there is a disadvantage that this could be over-invasive in about 35% of patients. So let me elaborate on this point with some data. Now, this is one study from Gaheliani, and there are several papers which support the same point that I'm trying to make. Now, they, in their study, they had a group of 133 men with non-obstructive azoospermia. Now, out of these, 65 were subjected to microdissection and 68 were subjected to a conventional biopsy. The sperm retrieval in the conventional group was about 38%, and in the microdissection, it was about 57%. So you can say that the microdissection has the highest chances of sperm retrieval. But if you look at this data the other way, then you would understand that even in conventional biopsy, you would be picking about 35 to 40% of patients. So if it is a staged approach in which first these patients were subjected to a conventional biopsy, then about 35 to 40% of these patients would have been spared of a microdissection, which, whatever the literature may claim, is an invasive procedure, and there is a lingering pain after microdissection and a significant discomfort which lasts for several weeks even after the procedure. So the other thing is that the needle aspiration biopsy, there are certain centers where techniques of microdissection are not available. So these centers are only doing needle aspiration biopsy, or they are doing conventional biopsy. Now, if they don't find sperms, then they freeze eggs and they refer the patient for a second sitting microdissection at a later date. Now, this approach has several disadvantages because, as I have discussed earlier, that needle aspiration biopsy is not exactly an innocuous technique, and it has the potential for suppressing the spermatogenesis. And since these patients are already extremely compromised with only focal areas of spermatogenesis, so it is not a good idea to do a needle aspiration biopsy and then schedule a microdissection or any other microscopic procedure for sperm retrieval at a later date. So the ideal technique should be something that everybody can practice, something that is least traumatic to the organ, that is the testis, and something which maximizes the chances of sperm retrieval. So this is again an approach that has been popularized by Rupin Shah sir. The SSSSR technique, that is the single stage sperm retrieval technique. In this, what we do is that we do 3 attempts of a needle aspiration biopsy, no more, because like doing more than 3 can cause significant testicular hemorrhage, and it can produce a hematoma which may compromise the microdissection, which is to be done in the same sitting. Now, if the needle aspiration biopsy, it is just a quick look. If it fails to unravel any sperms, then we do a SST, that is the single seminiferous technique, in which we map both the testes. And by the time the second testicular SST sample is being examined, we proceed to doing a microdissection on one side. So all this is being done in the same session. Microdissection usually is limited to one testis. Now, if the NAB, if the SST and microdissection, which is done on unilaterally, do not reveal any sperms, then we stop. And then this patient is given some kind of a hormonal treatment that we would be talking about later on. And then the microdissection of the virgin testis is done maybe after 5 to 6 months of hormonal treatment. So this is a small data in which 40 patients of non-obstructive azoospermia were subjected to a staged approach in which needle aspiration biopsy and SST revealed sperms in 14 patients, that is about 35%. So this is correlating with the study by Ghaliani, in which they found sperms in about 35 to 40 patients by conventional testicular biopsy. In the rest of the patients, a microdissection was done. So after microdissection, there was a further yield in 11 patients, that is about 27%. And in about 40%, that is, these patients did not have any sperms. So going back to what we have learned so far, non-obstructive azoospermia patients, there will be focal areas of spermatogenesis in about 20 to 60% of patients. If you go for a mapping or a needle aspiration biopsy, then it is possible to pick up sperms in about 35 to 40% of these patients. And in further about 25 to 30% of these patients, you will chance upon sperms by doing microdissection. So microdissection is to be done in a staged approach. Otherwise, it would be over-invasive in about 35% of patients, in which you can pick up sperms by simpler techniques like needle aspiration biopsies or the SST technique. So coming back to what we have discussed, we have to do needle aspiration biopsy in both the testes, followed by the SST in both the testes. Now, which testis first? Usually it is the right side, because right in literature is usually the larger site. And sometimes if there is a varicocele on the left, then obviously it has to be right. So whichever testis is larger, it has to be sampled first. And if the needle aspiration biopsy and SST, if they fail to pick up any sperms, then do a microdissection on one side only. If it is also negative, then abandon the procedure, give gonadotropins for about 4 to 6 months, and do a microdissection on the opposite side. So the second question that we need to discuss in detail is the timing of the sperm retrieval with respect to the ovum pickup. Now, there can be two approaches to this. Now, you can do testicular sperm extraction. You can freeze these sperms, and then you can do an ICSI in a staged approach. Or you can combine. You can do a testicular sperm extraction with a ovum pickup. So there is a study in which they had 3 groups. In this, the sperm retrieval was done on the day of the ovum pickup. In the second group, it was done 1 day prior to the OPU. And in the third group, it was done like in a frozen and thawed way. So if you see that the clinical pregnancy rates were more or less similar across all these 3 groups. Now, the problem is that occasionally there would be certain cases, particularly the Klinefelter syndrome, in which the sperms that you harvest are very, very few in numbers. You may end up getting maybe only 10 to 15 sperms. Now, these are very, very few sperms to freeze. And when you try to recover, then in 20% of these cases, you may not recover any sperms on thawing. And in 20% of such cases, when you go for a repeat TESE, then no sperms would be found. So the basic problem is concerning the difficult groups like Klinefelters, or groups in which there have been like 2 or 3 previous attempts and no sperms have been extracted. So in an ideal scenario in which the patient says that financial issues are non-existent and the wife is ready that even if no sperms are harvested, and if the ovarian stimulation goes waste, then it is not an issue with the couple. Then ideally, in such cases in which it is very difficult to recover the frozen sperms, or in which there is every possibility that sperms may not be recovered in a subsequent sitting, it makes every sense to plan the sperm extraction on the day of the OPU or at the most 1 day prior to it. The other scenario could be that there is a patient in which there have been about 2 or 3 failed procedures and he's not willing for a donor. Now in this also, since it may be very difficult to extract sperms in the second sitting, so it is better to combine the procedure, and if the couple is willing for a donor, then in that case, if the procedure of sperm extraction does not go through, then the ovum pickup can be combined with a donor sperm. The next question is that, is there any pre-treatment to improve the sperm retrieval rate? So I would like to quote a few studies. Now, one study is from Hussein. Now, he's a fellow with Niederberger. Now, in this, like, they had 612 men with non-obstructive azoospermia. So, they gave certain hormonal therapy to these patients, which I would be explaining. This actually seems to be contrary to logic, because in patients of non-obstructive azoospermia, which I described in my first slide, already the gonadotropins, that is FSH and LH, because of a lack of feedback stimulation, are on a higher side. So the question that earlier used to be asked is that, is there any point in flogging an already tired horse? So what he did in his study was that if the FSH was grossly elevated, which was like more than 1.5 times the upper limit, or if the testosterone was above 400, then these patients were excluded. However, those patients in which the FSH was not as high as 1.5 times the upper limit and the testosterone was somewhere in the lower range of about 350 to 400 nanograms per deciliter were chosen for this study. And they started by giving clomiphene citrate. It was given in a dose of 25 milligrams per day. After 1 month, they did a testosterone assay and also did an FSH assay. So if the FSH was not rising optimally, then they increased the dose of clomiphene citrate to 50 milligrams per day. Now, after that, if there was a rise in FSH, however, if the testosterone was not rising, then clomiphene was combined with HCG. As you would understand, HCG is similar to LH. However, if after giving clomiphene, there was no rise in either FSH or testosterone, then HCG and HMG were given together. So the aim was to increase the FSH to 1.5 times the existing value and to increase testosterone to double the previous limit, that is in the range of about 600 to 800. So they started with clomiphene and they gradually worked their way up. And they found that in about 10% patients of who received the hormones and who had azoospermia earlier on, they had 10% had sperms in ejaculate, which was an average of about 2.3 millions per ml, which was adequate to go ahead with an ICSI. And even if there was no sperm in the ejaculate, then if they did a surgery, then in that the sperm retrieval was higher in the treated group. It was about 57% as compared to 33% in the non-treated group. Now, this is another paper from Japan. In this, they had a failed microdissection. They had a group of 48 patients. Now, these were divided into two groups. Now, for 20 patients, a second microdissection was done after a period of 5 to 6 months without giving any hormonal therapy. In about 28 patients, they gave very high doses of HCG, which was 5,000 international units, 3 times a week. Now, they assayed the FSH after that. So in some patients, the FSH, they remained on the higher side, but in some patients, the FSH, it went down. Now, what actually happens is that when you give such a high dose of HCG, the testosterone goes up, and testosterone, because of a feedback suppression, causes a decrease in the FSH. So in 15 of these patients in which the FSH decreased, they gave a very high dose of recombinant FSH, that is 150 international units, 3 times a week. Now, this is an extremely high dose. This is twice the dose which you would give for a hypogonadotropic hypogonadism. And finally, in this treated group, they did a microdissection after a period of 5 to 6 months of hormonal treatment. So they found that those patients of non-obstructive azoospermia in which there was a failed microdissection earlier, when they were given a hormonal treatment, then there was harvesting of sperms in about 1/4 of these patients, that is 6 out of 28. And no patients in which the therapy was not given produced any sperms in a second microdissection. Now, this is another another paper, which is from the Cornell. This is from Peter Schlegel group. Now, in this, they studied patients with Klinefelter syndrome. Now, Klinefelter's, as you would remember, in these patients, the FSH and LH are on the higher side, and the testosterone is on the lower side. So, all those patients in which the testosterone was less than 300, they were given an aromatase inhibitor. They were given anastrozole in a dose of 1 milligram per day. And if after the administration of anastrozole, the testosterone did not rise, then they also added clomiphene citrate and HCG. Now, what happens in a Klinefelter syndrome is that the testosterone is on the lower side and the estradiol is elevated. So ideally, testosterone in nanograms per deciliter divided by estradiol in picograms per ml should be more than 10:1. And if the ratio is reversed, then these patients were given these aromatase inhibitors. So what they found was that those men with a normal baseline testosterone level, now they had the highest sperm retrieval rate of as high as 86%. However, those men who responded to the treatment with aromatase inhibitor also had a sperm retrieval which was fairly similar to those men which had a normal baseline testosterone level. This was about 76%. However, the non-responders, that is those patients in which the testosterone did not go up despite the administration of an aromatase inhibitor, in them the sperm retrieval rate was far lower, which was only 55%. Now, you have to understand that the sperm retrieval rates which are quoted in this study are, they're pretty on the higher side. In Klinefelter's, though, the literature at best suggests a sperm retrieval of about 50%. In a practical experience, it is not more than about 20 to 40%. So in this slide, I have tried to simplify what we have surmised from the previous 3 papers. Now, in a patient of non-obstructive azoospermia, you would assay testosterone in nanograms per deciliter, estradiol in picograms per ml, FSH and LH. Now, if testosterone is normal, normal is anything more than like 400 nanograms per deciliter. The SI unit is nanomoles per liter, and 12 nanomoles per liter would correspond to about 346 nanograms per deciliter. So if testosterone is normal or high, that is in the range of 500 to 600, then these are not the optimal candidates for any kind of a hormonal therapy. If the testosterone is less and if the estradiol is high, which is seen in a patient of Klinefelter syndrome, then these patients can be given an aromatase inhibitor. You have an anastrozole, the dose is 1 milligram per day, and you have letrozole, the dose is 2.5 milligrams per day. Most of the practitioners would prefer anastrozole to letrozole because letrozole has some amount of erectile dysfunction associated with it. If testosterone is less and FSH and LH are also on the lower side. Now, in a patient of non-obstructive azoospermia, FSH and LH will never be very, very low. They would be borderline, on borderline, they will never be on very low levels. So in these patients, you can start by giving clomiphene. So after giving clomiphene, if the FSH goes up and if the testosterone still remains on the lower side, then you combine clomiphene with HCG. However, if after giving clomiphene, both the FSH and testosterone, they do not rise, then you give HCG along with HMG. If testosterone is less, if FSH is on the higher side and if LH is on the lower side, then you only give HCG, but usually you have to combine clomiphene later on, because if after the administration of HCG, the testosterone goes up, then by a feedback suppression, the FSH would also be suppressed. So in order to maintain a higher level, you have to combine the HCG with a clomiphene also. Now, talking about prediction of sperm retrieval, if you have a patient who has already had a few biopsies, and if he asks you this question that I have had a few biopsies done which have been negative, so what are the chances that microdissection would yield sperms? So this is one study which is from Ramaswamy and Schlegel. It comes from Cornell. So if no biopsy has been done, then on microdissection, the chances of finding a sperm, as we have studied earlier, is anywhere between 20 to 60%. Now, if that patient has had 1 or 2 biopsies, then the chances do not reduce significantly as compared to no biopsy. Howsoever, if he has had 3 to 4 biopsies, then the chances of finding sperms on a microdissection will go down significantly to maybe about 20%. Now, what is happening in this slide, try to understand that when you are taking multiple biopsies, then you are sampling more and more areas of the testis. So the chances of picking up focal areas of spermatogenesis are also going up. So if a conventional biopsy, which has targeted multiple areas of the testis, has failed to reveal any kind of sperms, then the similar picture would also be reproduced when you're doing a microdissection. So greater the number, the greater the area of the testis sampled, the more are the chances that the focal areas of the spermatogenesis have been hit upon. And if multiple biopsies are negative, the similar thing will also be reproduced in a microdissection. So what are the possible predictors of sperm retrieval? Age, there is a question mark because there are some papers which suggest that if the age is more than 40, then the chances of sperm retrieval, they go down. Testicular volume, testicular volume does not correlate because even if it is a small fibrotic testis, you can still find areas of focal spermatogenesis by microdissection. Similarly, any type of hormone, FSH, testosterone or inhibin will not correlate because you have to understand that hormones basically reflect the overall health of the testis. So it does not take into account factors like focal areas of spermatogenesis. So the hormones may be elevated. There can be a picture in which the FSH is extremely on the higher side. Testosterone is very much on the lower side. The testis is very small, maybe a little larger than the size of the sponge that you use for your surgeries. And still, by doing microdissection, you can still find focal areas in which there is a spermatogenesis. So Klinefelter's, as I have talked earlier, literature says maybe about 50%, but practical experience is that in about no more than 20 to 40% you will chance upon sperms in such testis. Then if you go back to the recommendations, in a patient of infertility, if the semen count is less than 5 million per ml, then a genetic testing is recommended for AZF-A, B, and C. So azoospermic factor, this is located on the long arm of Y chromosome. And if there is AZF-A and B, then the chances of finding sperms on microdissection is almost negligible. However, in AZF-C, there are certain chances. Again, the literature quotes probability of as high as 50%. Now, practically, azoospermia with AZF-C, I think it is very, very difficult to harvest sperms, maybe like 5 to 10% in such patients. The next situation is orchiopexy patients. Now, this is something which, as a urologist, we commonly encounter. So you can have a patient who is presenting to you at a very later stage, maybe 18 years, 20 years, 25 years. There are bilateral undescended testes and an orchiopexy has been performed. The testes are small, they are flabby. The patient is azoospermic. So the question is that if you go for a microdissection in these testes, what are the chances of finding sperms? So this is actually one situation in which there is a pretty high chance. There is a chance of up to 50 to 70%, in which if you do a microdissection, then you might find sperms. Now, this is a very interesting case report. This is about a 29-year-old patient. This comes from Japan. So he had bilateral undescended testes and they did an orchiopexy. So at the time of doing an orchiopexy, they did a conventional open biopsy and there was azoospermia reported from both the testes. Thereafter, after 10 months of performing an orchiopexy, they did a microdissection. Again, there was an azoospermia. However, they followed up this patient, and after 7 years of orchiopexy, they again did a microdissection, and this time they found sperms during the procedure. So the uh, crux of this description was that after an orchiopexy, it may be wise to leave the testis for some time and to allow that spermatogenesis to recover. So if you are planning for a microdissection in a patient of orchiopexy, then maybe like you should do it after 2 to 3 years of the orchiopexy. Similarly, in chemotherapy and mumps, there is about a 40 to 50% chances of finding sperms on microdissection. This is a very interesting slide. This again comes from Ghayliani. So this is a correlation of the histopathology with the concept of homogeneity and heterogeneity. If you remember at the beginning of my discussion, I talked about Sertoli cell-only syndrome. So in hypospermatogenesis, maturation arrest, and Sertoli cell-only, they did a conventional biopsy and they did a microdissection. So for Sertoli cell in a conventional biopsy, the chances of finding sperms was only 6.2%, which went up by 4 times when they did a microdissection. However, they found sperms in only 1/4 of their patients. In a maturation arrest, in 1/3 patients, they found sperms, and the sperm retrieval was more or less same whether they did it by a conventional biopsy or a microdissection. And in hypospermatogenesis, there was a very high sperm yield of about 92% in a microdissection and about 84% in conventional, which also were like pretty similar. So try to understand what is happening here. In Sertoli cell, there is very, very high heterogeneity as compared to the other two conditions. So there is not just heterogeneity, but there is also very, very focal areas of spermatogenesis. So when you go for a conventional biopsy, then because of extremely focal areas of spermatogenesis, the chances of picking up a tubule which harbors sperms is very less. However, when you do a microdissection, since you are sampling the testis more, so you are taking that heterogeneity factor also into the equation. So your total yield goes up as compared to a conventional biopsy. In maturation arrest and hypospermatogenesis, on the other hand, there is more homogeneity, much more as compared to Sertoli cells only syndrome. In maturation arrest, however, there will be fewer tubules which would be producing sperms. However, they would be homogeneously distributed. That is why the chances of picking up sperms on conventional and microdissection are more or less the same. And in hypospermatogenesis, there is not just homogeneity, but also a far greater number of tubules that are harboring sperms. So finally, the take-home messages are that many men with non-obstructive azoospermia will have few sperms. How many? About 20 to 60%. How many sperms? That depends upon the biopsy, the kind of condition that has led to the non-obstructive azoospermia. And this would hold true even if the testes are small and if the FSH is very much elevated. There are no predictors of success, and single testicular biopsy could be misleading, as we have discussed in the preceding slides. Pre-treatment with hormones may help. How much? In about maybe 10 to 15% of the patients, and though the number seems to be very small, you have to understand that microdissection and these sperm extraction techniques are an act of desperation, and therefore even an increase of 5 to 10% is something that the patients are look forward to very, very enthusiastically. So SST is relevant. SST mapping should always be done before microdissection because it is a much less invasive technique as compared to microdissection. In fact, you can end up taking 60 samples from both the testes by SST and can have the patient go to work the next day, which is in contrast with microdissection. SST would sample larger testes better, something which is not fibrotic. It would sample the superficial tubules better. The remaining patients should be subjected to microdissection. So those testes which are small, fibrotic, in which there is no significant seminiferous tubules popping out on in the SST technique, should be subjected to microdissection. The first chance is the best chance. You cannot have a patient undergo a needle aspiration biopsy and then undergo a microdissection after 2 or 3 months, because that would lead to a suppression of spermatogenesis. So you have to combine everything, that is the needle aspiration biopsy, the SST and microdissection in the same sitting. A good andrologist and a better embryologist is indispensable. An andrologist can give a sample, but to dissect it and to repeatedly look through the sample is something which only a good embryologist can do. So basically, whenever a sample is provided, then the embryologist would dissect, tearing it apart using needles. He can, like, some of them, like, they squeeze it through a microforceps, some of them cut it through the micro scissor, the aspirate, and then they examine it, they spin the sample, they form a pellet, they suspend it, they form a micro drop. So the rationale is that you have to examine, incubate, and you have to dissect until you go cross-eyed and there is no possible chance of picking up any sperms from the sample that have been provided. So as you can understand, a good embryologist is indispensable to a patient of non-obstructive azoospermia. Now, the technique that we have discussed has the best retrieval rate, and this is actually least traumatic to the patient. So this is a brief review of non-obstructive azoospermia. I hope that I've been able to contribute to your already existing knowledge, and thank you so much for being a very patient audience. Thank you so much. Manu, phone do.
पापा क्या आप कैंडी लेना चाहेंगे?